Hi everyone, my name is Christina G, and today I will talk about joint work with Ahmed Allah and David Sonntag on a large-scale study of temporal shift in health insurance claims. This work was motivated by many shifts that occurred during the COVID-19 pandemic. For instance, the sepsis alert model that was deployed at the University of Michigan had to be deactivated in April of 2020 because it was giving false predictions due to changes in patient demographics. In a large health insurance claims dataset, we also saw many shifts. For example, non-urgent services like office visits declined in 2020 because CDC guidelines recommended postponing them starting in April 2020. We also saw a large drop in condition claims, yet the frequency of drug prescription rates did not change. That reflects how patients were still affected by chronic conditions, but received less care for them from doctor visits. To better understand these shifts, we want to identify them from a large dataset. So to do that, we first need to define temporal shift. Many prior benchmarks flag a decrease in model performance from one year to another as temporal shift. We argue instead that we should be comparing the historical model to a newly fit model if there was sufficient data to fit a good model. And the intuition behind this definition is that temporal shifts can only really be addressed if there is new data that can be used to update the model, and updating the model would lead to better performance. So with this idea, we then perform a large-scale retrospective study for temporal shift, and there are two motivations. First, we can identify potential causes of temporal shift from a retrospective study using our definition, and then monitor those causes in the future so that we can then detect temporal shifts earlier, even when we don't have data to fit a new model. And second, if we have these historical examples, we can then investigate different strategies for improving model performance when there is limited or no post-shift data, and then use those strategies going forward. So to formalize our definition for temporal shift, we say that an outcome at time t within a subpopulation ht is affected if this equation holds. So let's break this down. First, we have phi, which is a metric that reflects clinical impact. It could be something like AUC. This metric is evaluated on the dataset at the current time point t. We are comparing the model at time t with the model at time t minus 1, and both models are being evaluated on a subpopulation defined by HT. So putting that together, what our definition says is that temporal shift occurs if the performance of a current model on current data is better than the performance of a previous model on current data. And in contrast to prior benchmarks, what those definitions are comparing is the latter to the performance of the previous model on previous data. And I want to point out here that other works also use the same definition as us, but we want to formalize it here so that we can use it in our algorithm to test for temporal shift. So the first step of our algorithm is to learn models to predict the outcome y from features x that occur before the prediction date. We fit two separate models for the time period t minus 1 and time t. The second step is to define the subpopulation that is being evaluated. And this can be the entire population of patients, or it could be a predefined subpopulation based on patient etiology. We also create this algorithm to automate the discovery process for subpopulations that are more likely to be affected by temporal shift. Here, we use the new model and the old model to create new labels for the samples for where the new model is better calibrated. Then we fit a classifier to predict these new labels from the original features and outcomes. And the reason we use this classifier is because it gives us this more generalizable description for the subpopulation that might be affected. So with the outcome model and the subpopulations, the final step is to test the definition. First, we check the criteria and the validation data to see if the models are well fit enough to capture distribution, and if the confidence intervals for model performance suggest that our definition might be satisfied. If this holds, then we perform a hypothesis test for our definition for temporal shift using the held-out test data. So putting that together, the 3 steps are learning models to predict the outcome, finding a subpopulation that might be affected by shift, and then testing our definition. And in the baseline version of this algorithm, we would swap in the baseline definition for the last step. So now that we have a way to test for temporal shift, we want to use it to perform our large-scale retrospective study. So here, our goal is to scan for temporal shift in many outcomes across multiple time points, and either within the entire population or some discovered subpopulation. But the algorithm we create for this has 3 steps as well. First, we apply our test to each task individually. Then, to account for multiple hypotheses, we control the false discovery rate, and we correct for the number of tasks that satisfy the validation criteria where we actually ran the test. And then we examine clinical significance to see what the impact would be. So to demonstrate this algorithm, we perform a large-scale scan on the health insurance claims dataset. We look for temporal shift annually from 2015 to 2020 in over 1,000 different tasks. And the outcomes here are defined as whether a code occurs for the patient's insurance claims in the next 3 months. The outcomes are based on the most frequent initial condition diagnoses, abnormal lab measurements, and procedure groups. We have a large data set with over 1.6 million patients and over 15,000 features. Here's an example of a task with temporal shift. So we are comparing the performance of a current model and the previous model evaluated each year for the colonoscopy procedure outcome. What we see is that in 2020, the current model is significantly better, and this agrees with clinical knowledge because colonoscopy is a non-urgent procedure that was postponed during the pandemic, and there were many other features that were affected by the pandemic, and that leads to domain shift since that was used to predict the outcome. So how do our algorithm and the baseline perform on this task? Well, here we've plotted the confidence intervals computed by our algorithm in purple and by the baseline in green. We're comparing the intervals to the statistical significance threshold, the dashed line in black, and the point estimates to the clinical significance threshold in yellow. Our algorithm is capturing the difference between the two models at time t, while the baseline is comparing the performance of the 2019 model in 2019 and 2020, and the baseline fails to capture potential improvement of the new model. So for this task, only our algorithm is able to detect the shift in 2020. Here's an example of a task that doesn't have temporal shift. Because the performance of the current model and the previous model are the same in both years, we would not say that this task is affected, and our algorithm does not detect shift in any year as shown by the purple intervals. In contrast, the baseline erroneously identifies shift in 2018 and 2020 because the model performance dropped as the outcome was harder to predict in those years. So now that we understand how the algorithm works, let's look at the results from our large-scale study. Here we've plotted the proportion of tasks in each year for each outcome type that are detected to have temporal shift, with the results for our algorithm in solid lines and the baseline in dashed lines. First, we see that 9.7% of tasks are detected by our algorithm as affected by temporal shift. The majority of these tasks are in 2020 because of the pandemic, and prior to that, lab outcomes account for the majority of tasks with temporal shift because lab concepts and availability tended to change more frequently than other types of concepts. Additionally, for 93% of the tasks, the subpopulations that were discovered by our algorithm were affected by temporal shift. That suggests that if we just monitor temporal shift at the population level, we would be missing the adverse effects of using outdated models for some patient groups. And that means that just monitoring at the population level is actually insufficient to determine when we need to train a new model. Finally, to understand the clinical impact, we also examined some case studies. So first we looked at, because the majority of these tasks that were affected were in 2020, what exactly is the domain shift that's happening? And we found over 700 features that were affected at a univariate level when we looked at covariate shift. We also examined label shift, and we saw that there were 4 out of the 6 low eGFR lab outcomes were affected by temporal shift in 2018, and this was driven by a switch from the MDRD to the CKD EPI formula. As a way to address this shift, we can combine the 6 concepts into a single outcome, and then the model in 2017 performs well when evaluated in 2018. As a final example, we saw a sharp drop in inpatient consultations among patients with coronary heart failure or atherosclerosis in 2019. When we discussed this with the insurance company, they brought up how the Medicare reimbursement policy no longer covered inpatient consultations starting in the middle of 2018. And because these two diseases are much more common among Medicare patients, these features served as a proxy for Medicare status, and that explains the conditional shift that we saw. So the takeaways here are, first, we can look for similar concept policy or clinical practice changes in the future so that we can identify temporal shifts earlier as informed by this retrospective study. And second, if we use our clinical knowledge, we can then adapt the feature and outcome definitions to create models that are less affected by temporal shift. So to summarize our contributions, first, we firmly define temporal shift as comparing against the current model and current data. Then we create algorithms to test and scan for temporal shift. And finally, in a large scan on a health insurance claims dataset, we found that temporal shift is a widespread problem in healthcare settings. I would like to thank many people at Independence Blue Cross at MIT for your input on this work, and I'm happy to take questions. Thank you.